In this episode, we explore the world of trauma Dr. Gerbrand Lindeque and learn about the impact that the operational flow of hospitals has on both patients and staff in South Africa. Welcome to Apax Empowered, Doctor.
Trauma and trauma surgery is a department or a speciality that's very close to my heart. I've had some experience all over the country in South Africa with trauma and trauma surgery, from Gauteng to different hospitals, the Northwest, Western Cape, and I spent almost a decade of my life already in trauma surgery and in the emergency department. And it's absolutely wonderful to have a patient that comes in that is in dire need of medical attention, and you can help them and they can walk out or get better very soon. So I think it's very important for any healthcare system, health hospital, to have a trauma and trauma surgery department that is well functioned and well run to get that medical treatment to patients. Yes, so that's basically my idea and my background.
Incredible. Could you maybe give us some insight on the journey for the patient as they arrive at the state hospitals?
Yeah, so I've only worked in state hospitals, and obviously if you're a patient and you have an emergency, you're going to arrive at the hospital either with your own transport, with somebody taking you there, with an ambulance or something like an air ambulance or a helicopter. And then when you arrive there, there's usually two routes that you can take. If it is a medical emergency, something like a heart attack or asthma attack or other non-traumatic, you go to the medical emergency unit. And then if there's something traumatic like a car accident or a fall from height or a stab or a gunshot, then you're going to go to the trauma surgery unit. And then once you enter there, and that's where I can speak more about, is the trauma and trauma surgery unit, you get categorized. You get categorized based on the severity of the injury that you sustained. And the category is red, orange, yellow, and green. And that category is also based on your vitals, like I said, and also the trauma you sustained and how early you need medical intervention or a doctor to look at you. When you're a red, you need immediate attention, right? So those type of patients that take directly through to a unit or to an area where a doctor is permanently, so that when that happens, the whole protocol is activated and then that patient can get medical attention. If it's a orange and then a yellow patient, they say around about an hour or 2 hours, and a yellow patient 2 to 4 hours before they need medical attention. These are non-life threatening injuries, right? But that still warrants urgent medical attention. And then the less severe form is obviously the green patients, right? And that is a patient that can wait up 12 to 24 hours to be seen. Usually it's less. But they are patients with a stable fracture,
yes,
or somebody that has a piece of glass that's stuck in their arm or something like that.
But can you give us a little bit of background on that waiting room then? If a patient has to wait that long, what happens in that time that they wait?
If you talk about the green patients,
yes,
right, that wait, obviously it's a long waiting room, right, or long period that you have to wait. While you are waiting, also depending on the severity of what it is, it can either be in a chair, right, or on a bed. Mostly the green area is a chair, in my experience. And when they wait, you do a little bit of admin stuff, because obviously if a patient arrives, they need to be registered. We need to know the name, the surname, the age, any other comorbidities, etc. So there's a whole admin area as well where they start doing that. And then there's different setups in different hospitals. So if you're in a waiting area, sometimes there's 20 to 70 patients that sit on chairs waiting to be seen by a doctor. I know there's some hospitals that have 1 or 2 TVs that they can look at. Some of them also overlook the trauma unit. And I think it's not that it's important, but I think it's wise to also see that these doctors are extremely busy with other urgent cases. But if they have that access to the doctors, well, sometimes they stand up and they walk to the doctor and say, oh, listen, doctor, I've been waiting now for 6 hours. And although you want to give them that opportunity, it also slows the doctor then.
I can imagine.
Overall. So, yeah, so you can sit in a chair or a bed, wait from 20 to 70 chairs. Some units allow a family member to be with you. Some units don't allow a family member to be with you. Yeah, so that's the green waiting area.
Yeah. And then you say the orange area sort of also shared.
Yes. So the orange and yellow area is where you also need urgent care. These patients are usually patients that requires a bed, right? So they usually go into an area where they get onto a bed, and then the nursing staff would start with them, undressing them, putting their clothes in bags, so that the family members can take it home. They do the vitals for the patients and start preparing the patients for when the doctor is able to see them, and also clocking the patients, because that's quite a tedious task, is to write everything down. What allergies do you have? What medications are you on? What's your previous surgical history? What operations you've had, etc. So that's what they do. And with this area, like I said, you're in a bed, and then usually these beds or bays are has curtains that you can draw as well. So it is an open plan area, but you have a little bit of privacy. If the sister or doctor, whoever, needs to examine the patient or get the patient undressed, then they just draw the curtains, and then, yeah.
And then we get to your specialty area, and that's the red area for trauma surgery. Tell us about the needs for you as a doctor in those spaces and the kind of traumas that you have to deal with.
Yeah, so that's the area where I liked working for the past decade of my life. In the red area, where a patient comes in and needs immediate intervention to be life-saving. These type of patients are patients that is severely injured, right? And a doctor is always available in that area. I think it's important here to say that it's not there's a lot of horrific stories that comes in one-on-one, but what I want to get at today is that those one-on-one horrific stories, etc., you can handle because you're one-on-one with a patient. But if something like 10 P1 patients come in, which is P1 means that they need urgent care or care immediately, then you have 12 patients at once coming in, right? And then they flood that red area, and you need to see, what can I do, what can't I do, who needs the most urgent care and who doesn't. So for me, that's the horrific story, right? Is if you're the doctor in the red area,
yes,
and you get a lot of patients at once, right, that needs urgent medical care or surgical care or interventions. So for me, what I like in that area is obviously a lot of space, right? Because if a patient needs intubation, right, I need to be able to stand at the head of the bed, right, to intubate the patient while other doctor puts up a drip for the patient and the sisters takes bloods and undress the patient or whatever is necessary. If the patient comes in and has a witness cardiac arrest, like after a chest stab, then we do something like what we call the emergency thoracotomy, where we open the chest directly to close the hole to see what's wrong. And that happens in the red area sometimes. So space is a very important thing for me there, because you need space, not only for the patient and for the doctor, but there's a lot of support staff around it. Of course. From the nursing staff that needs to get the things ready, and also access to all these instruments that you need that's close by. But even more than that, you need space for a porter to come in, or a porter to run to the blood bank to go and fetch blood and bring blood to the patient. Students that stands in the corner to watch what's happening on, or what's going on. Some units also include family members in the space, where there's a trauma counselor that takes the family and say, come, you're going to stand now here in this corner with me. I'm going to explain to you this and this and this is what the doctors are doing, so that they can also see, sometimes it might be traumatic, I suppose, but they can see everybody is hustling and trying to save their loved one. And then also you get all your clerks, etc., that needs to come in and needs to take info from the family. So it's a lot of people in a space.
Yes.
And now we've only spoke about one patient,
yes.
right? So for me, what I like is a space, right, where there's different bays for patients, and each bay has a lot of space, right, so that you can do interventions for that patient to save their lives, but also open space in the sense that if I come to a point where I have 12 patients in my red area, I can see what's going on with each of those patients at one stage while I'm standing like in the middle
yes.
of the red area. What I also enjoy quite a bit is the screening or the monitors of these especially red patients. When they get in, obviously our nursing staff connects them to their blood pressure and their SATs and their heart rate monitors, etc. And some units display that on big TV displays on top of the patient's bay, right? So at one glance, if I stand, I can visualize whichever trauma unit it is, from 8 to 22 beds, and I can see all the vitals of the patients and see where I need to intervene or what is wrong or what I need to do.
What would be the most important at that given time?
Exactly. So that's obviously there's different interventions for
yes.
different problems, right? But which patient needs the most urgent care at that stage? And what's also nice is, remember, with the nursing staff, is if it's an open plan design, I can instruct the nursing staff from a central point
yes.
To please give this medication for this patient in bed number 8, but this one I think we have to move now to CT scan. So I don't have to run around between small different rooms
yes.
to get the ball rolling.
It makes a lot of sense,
yeah.
Just to have the workflow all straightened out and everyone positioned
Absolutely.
where they need to be.
Absolutely. And I think for me, one of the biggest challenges was space, right? And I'm not only talking about patient space and staff space, right? But I'm talking about space for the equipment, right? To be close by. I have a pet peeve if I need something and they tell me, oh no, it's in the store. And then the store is locked, right? And the store is 4 minutes from here, especially in an emergency setting. Happens very seldom, right? But that means that one of my head nurses needs to leave, go and fetch a key, walk to a store, etc. So if everything is close by, in close proximity, then we get to do a lot more. Another thing is, remember, sometimes when we do surgical interventions for these patients, we need good lighting, right? So, and I'm not talking about good lighting, a nice light that you have in your kitchen. I'm talking about theatre lights. So some of these bays, which we sometimes call like our most important bays, has theatre lights coming from the roof, so that if we need to do something, we have that available as well.
That's incredible. I'm so glad that you touched on those points about lighting, storage and functionality of the space.
Yes.
Now that we've touched on the requirements for you as a doctor and then the patient's needs, tell us how the family members are being cared for in these spaces.
So I think you can categorize them in 2 different groups, right? You get family members that's also been in an accident, that's not as critically ill, right? And then goes to a different area, right? And in the same group, you get family members that's been part of the accident, but that's not injured at all, or was in a car close by, and they've seen their loved one get injured, right? So those are the people that know what's going on, and they get to the hospital with the patient or just behind the patient, and then they are a little bit more informed, right? And then the separate group is a family member that got a random phone call from somebody saying that, listen, patient X was in an accident, right? So these family members usually run in, right, frantically and say, do you have this patient here, or do you know this person? So those are the two categories that I think is important. If we talk about the first category, so a family member that is aware, right, of what's going on, what they usually do is when the patient comes in, we send them to the admin person first, because they need to open a folder for the patient, which is important, right, because we need to know what is the patient's name and age, what is their cell phone number, their comorbidities, etc. And because I cannot do anything if the patient's not registered. So that's actually the crucial part as well, to get them registered.
Yes.
That's what a family member does. And from there onwards, it depends, right? Some trauma units, and especially in the private sector in our country, has a trauma counselor that then takes that family member through the different steps of what's happening, etc., and communicates with that family member often, right? I want to touch here as well on communication, right? Because remember, the doctor is running around,
Yes,
right? So it's not always difficult it is difficult for him or her to communicate with the family members the whole time, right? Obviously, that's something you try, but it is wise to have somebody like a counsellor or somebody to help. Most of the government sectors, trauma units that I worked in, don't have that facility, but they do have waiting rooms for the family members. These waiting rooms are also very dull and bland, sterile, and sometimes outside, because sometimes there's just not enough space for everybody. And I think there's also a rules that some hospitals have, is they only allow one family member to wait. In the government sector, I enjoy that quite a bit, right? Because that summarizes a communication system between one family member and a doctor, and that family member can tell the rest of the family what's going on, because each family member has a question. So if each family member asks that question to a doctor, right, that takes a lot of time. So that's the one category. The other category is patients that runs in, or family members that runs in and they don't know what's going on, etc. So they usually go to the clerk, right, or the registration system, and then they ask them. Usually that patient's already registered, and then they ask them a name and a surname, etc. But some people come in as unknown. We don't know who they are, right? And then those people also come into the unit to sometimes see, is there somebody they know, or ask the sisters, like, is there somebody that was in an accident on this road or not?
Them.
Exactly. What's also very important here, which only some trauma units have, and I also think is vital important, is a family counselling room. Because we are all aware that if a patient is in a very bad accident, some of them demise, some of them don't make it, right? And the doctor needs to break that news to the family members that arrives. And obviously there's different methods that doctors go through at university on how to break these bad news. But sometimes, in my opinion, certain trauma units lack the environment for these family members to receive the news in a tranquil environment where they can also start their grieving process. And what I want to add on here as well is sometimes we get a patient that is not demised, right, but we know is not going to make the night or the day. And it's also important to give those family members an opportunity to see that patient, right, and to have a place where they can get together and one or two at a time go and see the patient and talk to the patient if possible, or if not, and then go back to their family members and start their grieving process.
And would you sort of put a limit to the amount of time they would be able to spend in that room?
That actually depends on the nursing staff and how busy we are, to be honest. In the past, I've had a previous call where we only had one patient in our red area, right? And it wasn't busy, and I was busy in the yellow area for the most of the time. So I told the family members, if you want to sit next to the patient's bed, bring a chair, come, sit. Because we know that patient has a bad brain injury and is not going to survive, right? So then they can spend as much time as they would like. In comparison, if you run 12 resusces, then everybody must be out. Then there's no time for space for family members at that stage to get to see the loved ones, because we need to get things going, and especially for other patients. And I think it's important to realize the ethics around this as well, because you want to give those family members opportunities to grieve or to say goodbye to their patients, or their family members, but also next door there's somebody else that they don't know that is also critically ill, that we need to respect that patient just as much as the one that might not make it.
Then lastly, Gerbrand, what happens when the patient's numbers outweighs the capacity of your medical spaces?
Yeah, so I think that's where, that's what we sometimes call a mass casualty, where there might be a big accident that happened, like a plane crash or a bomb or something. Hopefully that never happens. But then we have different protocols that sets into play, where different people come in and take control of that trauma and casualty environment. And it sounds like chaos, but it's not. It's quite an organized protocol of who goes where, who gets which demands, or who is in charge of which area, and who is managing the patients, who's managing the reporters, who's managing who. So that's a thing that hopefully never happens, but is well described in very thick and extensive protocols.
And then lastly, Gerbrand, we also care about our doctors, and they would also need a space to recharge. What's the setup there?
Yes, I'm very adamant that I think it's very important to create a space for your doctors and nursing and allied staff to have a space where they can remove themselves out of a very tense environment, like you said, to recharge, eat something, drink something, maybe sleep, and feel better to get in. Obviously, the doctor won't do it if there is life emergency interventions that needs to happen. But I mean, it is a natural occurrence that in any call, if you're doing a call, that there will be a time where you can have something to eat or drink and go and recharge. So I think it's very important to have such a space. What's also important for us to remember is that these staff also work with protective gear, but you work in an environment where it's extremely sweaty, right? And there's a lot of blood, right? And dirt that goes on, and bodily fluids, right? And there is a chance that it might get onto your skin or somewhere. So I really enjoy, if something like that happens, is to go and take a shower, right? That's close by in the emergency unit. I can shower, feel better, eat something, put on my new clothes, and then get back to the running. So I think something to have, not only an area where you have a kitchen area where you can eat, but also a recovery area where you can maybe just quickly take a shower, or you can just rest your feet or something for a few minutes, because then ultimately I believe you'll be a better doctor if you've recharged a little bit for the rest of the patients.
And what you are saying is currently this is not in place?
It depends on emergency unit or trauma unit to trauma unit. There are trauma units that has these facilities, right? I don't think they are the best facilities, to be honest, for the doctors. So I do think that it can be uplifted and upgraded. And I think there's also a fine balance, because you don't want your doctors to stay there the whole time and your nursing staff to stay there the whole time. You want them to be on the floor, right? But you do want them to also have that opportunity to recharge or to recuperate. But yeah, there are some units that has such a space, but most of the units that I've worked in lacks that area.
And also, I assume, a space to lock your valuables.
Yes, yes, because we do work in an environment, and especially in the government sector with the patient population, that sometimes are brought in by the police or that was part of criminal activity. And unfortunately, sometimes they continue with that criminal activity in the unit. So you do need a place, right, where you can put your valuables and your food and lock it, right, so that you know that you're safe. Because I always say, and multiple professors say this as well, is that if you're safe, then you can take care of a patient. If you're not safe, then you can't.
Excellent. Thank you so much for the informative information that you shared with us today, and we look forward to seeing more of these spaces being reinvented for trauma, and we wish you the best of luck in your career as well.
Thank you very much.